to save some time, probably I will bring forward the Q&A session to now, which I actually have a few questions from the Google Meet. I think there's 2 questions for Dr. Lutfi. She's from Sakuntala. I will invite Dr. Lutfi to have a seat here. So she's asking for painful procedure done as daycare, such as burn, dressing change. Would you want to give, or how do you give oral anxiolytics such as syrup midazolam before line insertion or dressing change, and what dose? And she mentioned that patient is planned for IV ketamine sedation.
Okay, for oral sedations, normally the dose is 0.5 milligram per kilo of oral midazolam, and normally we give about minimum is half an hour before the procedures. It takes time to work, and if the patient is sedated, and we can proceed with the IV line insertion. And one thing about oral midazolam is sometimes the onset is a bit unpredictable and takes longer time to work. But the following effect is for example, the eliminations and metabolism take longer time. So they might be asleep a few hours after that, even though you just give that for pre-med. And yeah, is that answering? So once we get a line, we can give ketamine, and for the painful procedure sedation, sometimes we have to supplement with a bit of fentanyl as well, intermittent fentanyl, ketamine and intermittent fentanyl. Ketamine itself, sometimes a patient a bit light may not be cooperative, so the fentanyl can have a synergistic effect to help during the procedures. Yeah.
Yeah, personally, me myself give syrup mida as well for pre-medication, especially for autistic child. So there's a question: if patient come for daycare, how do you give syrup mida? So do you think syrup mida should be available all the time in a daycare center? Because in our hospital setting, our syrup mida need to prescribe via the hospital. So what's your suggestion on this? Actually, this patient come for daycare.
Patient come for daycare. First of all, if the drugs, we want to make sure the drug is easily available during the day, and this patient need to be planned earlier so that we have enough time to monitor even after the procedure sedations. And whether it's yes, you have to prescribe, and in our settings, you need someone a doctor to make sure that the drug is safe, and normally one doctor will in charge with the syrup midazolam for the pre-med in a daycare.
There's another question. For IV sedation, do you co-administer with glycopyrrolate? Any antisialogue like atropine? Do you routinely give? This question from Sakuntala.
Okay. For sedation, okay.
For IV ketamine sedation.
IV ketamine sedation. Okay. Personally, for example, in the case of a CT scan, CT scan is very brief. Because sometimes in this patient they have respiratory issues. They go for CECTs, CT thorax, and I don't routinely give antisialogues, like glycopyrrolate or atropine for my ketamine if it's just a single dose. And this is my personal, because some of the studies says that no difference. And this is my opinions. I don't give routinely.
Yeah, I agree with you. Actually, if you give glyco or atropine to ketamine just to avoid the salivation, it's actually you impose more harm than benefit, because ketamine itself can cause tachycardia. So with glyco, you will double the heart rate. So eventually, patient will have persistent tachycardia. You don't know whether patient in pain or patient awake or patient is a side effect of the drugs. Okay. So just now, Dr. Lutfi, we have mentioned about treachercholine having MRI down there. Yeah. So how do you deal with it? What's your personal experience?
Okay, first of all, we anticipate this is difficult patients, difficult airway, difficult IV access, and a lot of comorbids. And our options will be, we make use of our operating theaters, like we intubate the patient in OTs when we have a lot of personnel, we have helps, we have all the equipments there with the lighting, all those things. We are familiar with our environment. Intubate the patient and sedate the patient, bring the patient down to the suites, MRI or any procedure suites, and come back to OT for recovery, rather than put the patient in recovery in the remote area. Probably because sometimes need a longer recovery, and this patient can be extubatable most of the time because of the thing that we give probably is a short acting of fentanyl during this airway manipulation, not giving any morphine. So observing in recovery in operating theaters where all the staffs and all the team members are a lot, this is one of the technique that we use in HTA. So we can avoid this patient going to PICU, because our PICU, PICS ICU, intensive care are very limited. If it's just a short procedures, but with the difficult patients, sometimes we just observe longer in our PACU in recovery area in our setting. So this is normally what we do. Okay.
Right. On the other hand, I very agree with management of Dr. Lutfi. So on the other hand, I have personally done before patient with a difficult airway in which the upstairs, the theater is too full for me to slot into secure the airway. So what I have done is I put on sedation, but it's pre-sedax, no propofol, and intermittent give boluses of ketamine. This the other option. But you have to remember that if you want to be brave enough to do so, you have to make sure the MRI is as short as possible, not more than 1 hour or 2 hours. All right. Do you use ketamine in less than 3 months old, Dr. Lutfi?
No, and most of the guidelines, okay, I come back to that. Okay, first, why most of the guidelines in the hospital, they say no ketamine in patients less than 3 months. Why? This is controversial because a few of the animal studies, saying that ketamine in younger patients can cause neurotoxicity. But there's no proven yet in terms of human studies. But they still take that because of that guideline. They still stick to the less than 3 months no ketamine. But personally, for me, I do give for very particular patient. For example, patient with the cardiac, cardiac problems. Sometimes other option is just sevoflurane induction. For example, we want to give GA for the patient, sevoflurane, or we give a bit of ketamine for this patient, for this cardiac patient, even less than 3 months, just a single bolus dose. Yep.
Thank you very much for your answer. I have a similar thoughts on this as well. And actually, I have a question on intranasal sedation as well. So I have many people come up to me, how do you give intranasal pre-sedax? And what's the maximum volume? And how effective is it? Have you done before?
Okay, I've done few, not many. Most of the time it's not necessary, not needed. Okay, basically in pediatric patients, the delivery of intranasal drugs, it depends on the effectiveness, like how do you deliver it. If you use atomizer for any intranasal drugs, it is good absorptions, but the child need to be cooperative. And how to get the child cooperative to deliver this, sometimes we need a bit of sevoflurane and give this. Otherwise, if no sevoflurane, you have to make sure that the child is okay. So the dose maximum normally in the literature, they say, and also from the experience of the seniors, and we shouldn't go more than 1 ml for each nostril. You go for more than 1 ml, most of the drugs we go to the oropharynx and they just swallow rather than going to the nostrils. Okay. If we have, for example, the dose is 1 ml, so the dose is 2 ml, just divide the dose into each nostrils. So if it's too much, also, you just give half first, and then you repeat probably another 10 minutes. probably in 5 to 10 minutes you repeat the rest of the bolus dose. So you have to divide the dose. So each squid is 1 mils normally. This is most of some of the literature and also from the experience from the seniors.
All right, thank you so much for your answer, Dr. Lutfi. So far, I have no more questions from the internet.